So this patient is an 11-year-old girl who was first seen at Lurie Children's in March 2018 for a rash that developed the prior summer. These were kind of annular lesions that were initially thought to be ringworm on her arms, but then eventually she had spread of erythema to the malar region, fingers, and the rest of her arms, and progressive fatigue, weakness with difficulty getting out of bed and activities of daily living. She had a couple of falls at school and home, and she was seen to kind of have gait abnormality. No dysphagia, no dysphonia. She did seem to have some intermittent abdominal pain, and her PCP saw all of this and suspected some kind of autoimmune process and started some prednisone while trying to get her in to see our service. She didn't have any weight loss, hematochezia, or other GI symptoms, and the abdominal pain might have started around the time that she began prednisone. Her past medical history and past surgical history are as displayed here, and I just would want to highlight the anxiety because this is a patient who actually throughout her course has had very, very intense anxiety with panic attacks and sleep disturbance and so on. And I think in some ways it complicates the presentation of what I'll go into next. And then there is some family history of autoimmunity here. In terms of her initial exam, so she had classic Schall sign, Gottron's papules, periungual erythema, malar erythema, and also some palmar erythema that were documented. She also had bilateral symmetric proximal muscle weakness, as documented here, difficulty performing a sit-up. Her Gower sign was technically negative, but it was clearly difficult for her to get from sitting to standing. And even at her initial presentation and initial hospitalization for diagnosis and initiation of treatment, she was very anxious, very tearful. Rest of her exam, including her GI exam, was normal. And her initial labs did show elevation of the muscle enzymes that were drawn. Her LDH, I think, was hemolyzed, so couldn't be run. Von Willebrand factor antigen was elevated, consistent with some degree of vasculopathy. Neopterin was also elevated at onset of the disease. She ultimately was found to have MI2 antibody, and her MRI was consistent with JDM. So her initial admission, she was started on IV pulse methylprednisolone treatment, subcutaneous methotrexate. Because of the burden of skin disease and muscle disease, IVIG was actually initiated at the time of diagnosis rather than waiting to add it on. And then just a little bit of Plaquenil as sort of kind of adjunctive therapy for the skin disease. So she was discharged home on weekly IV pulse methylprednisolone therapy with lower dose oral prednisone, kind of rapidly tapered to about 20 milligrams a day as a maintenance dose, and then continued on weekly sub-Q methotrexate, monthly IVIG, the Plaquenil that I mentioned, and she was eventually able to start physical therapy after a little bit of a delay, just with insurance and stuff being what it is. So, with intensive, early intensive treatment, she did have seemingly a good response to her care. So she actually had clearance of rashes really by about 4.5 months, which is pretty remarkable. Her CMAS normalized by about 7 months. She had a component of deconditioning, and the physical therapy helped with that. Her aldolase was the last muscle enzyme to normalize. That took about 7 months to normalize, but everything else actually normalized within a month or two. And over the course of that period of time, she was able to have her IV pulse steroids spaced out and then eventually stopped by before 6 months of treatment. She had IVIG on board monthly for about the initial 9 months of treatment, and that was stopped. But during this time, she did have a number of different kind of pain complaints. There were these intermittent periods where she would have sometimes even quite intense abdominal pain, but without other GI symptoms. And this would kind of wax and wane. Headaches as well, which were often related to stress, and again, very severe anxiety. It took a while to get the family into a place where they could see a mental health provider, but eventually she did start seeing a therapist. So 7 or 8 months after the diagnosis and initial onset of treatment, she started, in addition to having these intermittent bouts of belly pain, started having nausea, and the abdominal pain she would have at times with it was very poorly localized, both by history and on exam. Sometimes there would be periods where her family felt like it was very much associated with medication administration. So I take my medicine in the morning, I'm nauseous in the morning, have an upset stomach, and then it resolves by later in the day. Other times it seemed to be associated with stress or anxiety, either school-related stress or disease-related stress, say around the time of IV infusions, things like that. So some basic empiric treatments that were initiated, just given that there weren't any localizing signs and that from a JDM standpoint, she seemed to have improvement of her disease activity overall, A little bit of Miralax was attempted by her pediatrician for presumed constipation, didn't really seem to help. Her omeprazole, given that she was on steroids, was increased, and initially when that was done, there was actually near resolution of pain. So the thought was maybe this is kind of gastritis causing some abdominal discomfort and nausea. But then about a month or two later, she actually did start to have bright red blood in her stool and a hemocult positive stool at her PCP. There was again kind of a question of whether she might be getting constipated. There was concern for a possible fissure, though she refused a rectal exam at the time of her PCP visit. Interestingly, she didn't actually have abdominal pain at this time, didn't have nausea or vomiting at this time, didn't have diarrhea either. So given just these months and months of very vague complaints, it seemed like time to refer to GI for further evaluation. And so within, within 1 week of that episode of bright red blood per rectum, she was seen by her gastroenterologist, and she, in that interim, did start to have abdominal pain again, though they, retrospectively, that period where I said she wasn't having pain, they started to wonder, well, was she having some mild aches, you know, that they were kind of picking up on when they would ask her more questions. There might have been a little bit of early satiety and bloating, but very mild if present. And our gastroenterologists were able to perform a rectal exam. They thought maybe there could have been an internal fissure. They confirmed hemocult positivity still on their exam. But an internal fissure wouldn't necessarily explain abdominal pain and nausea that were happening off and on. And so they went ahead and sent a fecal calprotectin and arranged for EGD and colonoscopy. Prior to the scopes getting done, the calprotectin result came back as roughly tenfold elevated. So very concerning for intestinal inflammation. So she underwent the EGD and colonoscopy. Just to be clear, though, during this entire period of time, she still had completely normal strengthened skin exams, and even her nail fold capillary loops had very nicely healed. There was no dropout, minimal, if any, ectasia or tortuosity. So from the standpoint of JDM skin and muscle disease, she seemed quite well. So her EGD and colonoscopy, so there was a little bit of active duodenitis. There was like one focus with mild cryptitis. She had inactive chronic gastritis, but no like active, gastric ulcers or anything like that, though some chronic inflammation still noted. Esophagus was fine. And then basically what this is showing is in every segment of the colon, there was neutrophilic cryptitis, often with at least some crypt abscesses, and some mixed inflammatory infiltrate in the lamina propria, and some, in some segments, like some crypt distortion as well. So these findings are concerning for inflammatory bowel disease, and given that it's predominantly colonic involvement, the question came up of whether this could be ulcerative colitis. So the CMV and adenovirus stains were negative, just to make sure this is not an infectious colitis, and there were no other positive infectious studies. I didn't list everything here just for sake of time. So in discussion with our gastroenterology team, her prednisone, which at that point had been weaned to, relative to her body weight, a pretty low dose of 10 milligrams a day, was temporarily increased to 40 milligrams a day to quiet what was thought to be possible inflammatory bowel disease. She was continued on methotrexate and hydroxychloroquine. And then mesalamine, specifically the brand Lialda, was started as well for further treatment of this possible UC. And she had rapid resolution of bloody stools, abdominal pain really, really improved. Interestingly, though, MR enterography was performed 1 week after she had this increased dose of prednisone, and it was completely normal, which is a little bit strange if you think about it, that imaging study, which is quite sensitive, would be totally negative so soon after increasing steroids. So eventually she was tapered back down over a couple weeks to that 10 milligrams daily dose of prednisone, and she did start to have some recurrence of pain. It would be kind of intermittent. There would be some good days where she didn't really have much pain at all, and then other days where she would have bad enough pain that she was calling to get taken home from school. In order to make sure we weren't missing any other focus of inflammation, capsule endoscopy was performed, but that was completely normal. Repeat stool calprotectin was performed, still elevated, but improving relative to the prior measurement. And again, like nail fold capillaries were re-examined, totally normal, skin and strength were totally normal. One thought that I had is, clearly there's some kind of inflammation in the colon. I didn't think that hydroxychloroquine is causing that, but one of the known side effects of hydroxychloroquine is GI upset. And so I thought, she's stable from a skin disease standpoint. She doesn't need this adjunctive treatment. Let's stop it to make sure that that's not confounding our ability to track her pain level. And at her most recent GI visit, which was in May of 2019, her pain had improved and she hadn't had any bloody stool in a few weeks, which is, I don't think, really attributable to hydroxychloroquine. So we wonder, is that just the mesalamine starting to kick in? Or why would her symptoms be improving without like a major change in the treatment approach? The other thing to just know kind of globally during this time is she still struggles with significant symptoms of anxiety. And so we've also wondered, how much of her symptomatology represents inflammation versus functional overlay. Excuse me. And at my most recent visit with her, which was not listed up here, but it was just about a week or two ago in June, she actually had not had any abdominal pain for a couple weeks, no bloody stools for about at least a few weeks as well. So right now we're hoping that that represents improvement of inflammation, but finding it a little bit hard to track her symptoms relative to the degree of inflammation documented. So as we were evaluating her, we thought about a variety of causes of gastrointestinal symptoms in JDM patients. So of course, well documented is GI vasculopathy, which can be acute in the early active phase of the disease, or you can also see chronic endarteropathy with potential for pneumatosis or perforation late in the disease in the setting of otherwise apparently good disease control. But she didn't have any evidence of vasculopathy or microthrombosis or anything like that on her biopsies when she was scoped. So this seemed somewhat less likely. And then, of course, we wondered about medication-induced gastritis and duodenitis, for which we increased the dose of her omeprazole, and that seemed at least to help with symptoms temporarily. So if there was a component of that, it seemed like we had addressed it. We evaluated for opportunistic infection. She didn't have any evidence of like fistulizing disease process or symptoms, but that's something that's been rarely reported, including even I found a case of aortoesophageal fistula in an adult dermatomyositis patient. We haven't formally worked her up for dysmotility, and that might be something that would be worth considering, as there have been a number of reports of dysmotility along different segments of the GI tract in both adult and juvenile dermatomyositis patients. She doesn't have any dysphagia at the moment, though, but maybe something more distal. No evidence of pancreatitis. I didn't put it here, but she's had normal lipase, but there are some occasional case reports of severe pancreatitis in JDM. Few case reports of celiac, but her testing was negative and she didn't have the classic villus blunting on her small bowel and duodenal segments of the biopsy. And then I did find that there actually are a number of case reports of inflammatory bowel disease, both Crohn's and ulcerative colitis in adult or actually primarily adult dermatomyositis. Interestingly, there was actually a recently published study out of Taiwan where they did a nationwide cohort study because they are able to do that with their health system. And they found in adult dermatomyositis increased incidence of ulcerative colitis and dermatomyositis together. Didn't find that association with ulcerative colitis and polymyositis. So some next steps. Right now, given that she's not symptomatic and it's a little bit unclear what the exact source of her symptoms is, and we want to kind of minimize polypharmacy, our gastroenterologist thought maybe to kind of wean the mesalamine down to a lower dose, repeat her scopes, continue to watch calprotectins. But the questions I would kind of pose to you guys in the audience, number one, are there other diagnostic studies we should be considering? Could we still be missing GI vasculopathy? If so, how can we confirm that at all? Or are there other GI processes either related to JDM or not, that you guys would consider? And then there's kind of a lumping and splitting question here embedded in this presentation. Is this all JDM and, you get like a JDM enteropathy, or is this truly JDM plus IBD? And if so, suppose that her IBD type symptoms and histologic findings come back. What's the next step if she's failing methotrexate plus mesalamine? Do we go with TNF inhibitors the way classically you would do in an IBD patient, knowing that there's the possibility of inducing flare in JDM patients? Or do we actually attribute all of this to JDM and say it's one disease process and intensify therapies that you would usually give in that setting? And if so, what therapies? So those are a couple of the questions I have for the audience. 14, I think, or no, she's younger than that. She's young, 11. She's now like 12, 13, yeah, preteen. There's no family history of IBD.
So that's an interesting, very interesting case. And I would just say, just since I was asking you those questions, I'll just start. But I would think another drug that overlaps the two diseases would be a better start. I mean, I think mesalamine works in IBD, but it's not a real heavy hitter. And methotrexate, same. We use it in our IBD-associated arthritis patients a lot. But something like azathioprine or mycophenolate, would probably be, I think, a next alternative. I'd be a little reluctant about a TNF inhibitor, although, I've used it with calcinosis before, but a patient who's recently had systemic active disease, I'd be a little bit more measured in trying that. But it's interesting because one of the coolest immunologic things about new therapies in other parts of medicine are these cancer checkpoint inhibitor therapies, and they have a lot of immune-related adverse effects, the most common of which being gastrointestinal inflammation that looks like IBD. So whether this child happens to have a really high active, lymphocytes or adaptive immune system.
Thank you. That was a very interesting case. I have a somewhat similar patient, except her JDM preceded her GI symptoms by about 3 years. So when she really started having a lot of GI symptoms, her JDM was completely quiet. And she saw a local gastroenterologist and didn't involve me. And they started her on a little bit of prednisone, but Humira, and a month later she had psoriasis from head to toe. So I would avoid TNF inhibitors. She's now on Stelara and doing fabulous. So,
Interesting.
the interleukin 17 inhibitor.
For a second. I think, did Dr. Pachman have a question?
Kaveh, do you have her NKs?
We do. I mean, I check them.
And they're
as well.
okay?
Pretty sure. I'll double check that.
I'll tell you why. We had a child I'd like to talk about sometime, I think last year, was that who had a story somewhat similar to that, but without stools that were positive for any heme. His NKs kept on dropping, and he developed, that was the only thing he had, was pneumatosis intestinalis. And I have his MR if we want, but take a look. And when we treated him, he came back, and his nail folds were okay too. So what's the relationship of the IB, inflammatory bowels, no matter where its position is in the gut, to muscle? It's really cool.
Yeah. No, I don't know, actually. Brian, I think, has a mic.
Kaveh, I'm not sure I would worry so much about anti-TNF therapy. Although it's not fully published, in the UK they have that large experience of using largely infliximab, but I think some Humira as well, with good effect in their myositis patients and without flare. At least that's according to the UK group, especially Clarissa. And I've been thinking about the same thing with a patient of mine who had very long-standing but still mildly active JDM, strong family history of Crohn's disease, who now has Crohn's disease. And we want to kill two birds with one stone, same as you. And maybe ustekinumab is the way we should go, but I'm less worried about the anti-TNF. On the other hand,
My patient's JDM, like I said, and it's still quiet and has been for a few years. So it's, true and related. Who knows?
So just when we think about patients with skin disease and muscle disease, and they could be separate, like one could be active and one could be quiet, I'm just wondering if You can have manifestations of GI disease and JDM without having skin and muscle disease. So I've definitely encountered patients who look like they have totally normal muscle and skin processes, and then presented with like catastrophic GI issues that was ultimately attributed to JDM, and they had been worked up and down by gastroenterology and things like that. So I think thinking that it's possible that it is a JDM manifestation is still very reasonable. And I'm just wondering, just in the staining, just the biopsies are pretty superficial when they do the gut biopsies and stuff, but if there were biopsy samples that included blood vessels that could be stained for complement and things like that, if that might be helpful to try to understand what's going on.
Can I ask you a follow-up question?
Sure.
Like, suppose we did that and actually it looked like it really, there might be complement deposition, and that we thought maybe it is JDM related. If, given you've had some experience like with this, do you have a sense of what you would do to prevent a catastrophic outcome?
So thankfully I haven't had a large number of these patients, but then I think of this as a, an outcome we don't want. So I've used cyclophosphamide in cases like this, and some people know the patient I'm talking about specifically, but I think if there was evidence of gut disease that wasn't responding to what the aggressive treatment you've given, I think about escalating therapy. I don't know what others think.
Thanks.
Okay, well, just before Anne, did you do any contrast imaging of the gut, or to look at the bowel thickness or bowel wall edema?
MR enterography was done, which usually should be able to show you that, and there was no bowel wall thickening at all.
And the von Willebrand factor antigen is
Has
normal?
normalized, yeah.
Normal. So those usually are helpful clues in these gut vasculopathy cases.
Yeah.
But I have seen some patients with colitis too, some of which is inflammatory bowel disease, some of which is medication related, like from Cellcept and azathioprine and combinations of many immunosuppressive medications. Maybe not your patient, but.
Okay.
So I was going to kind of add what Lisa just said. I mean, you asked two questions. One is how do you diagnose the vasculitis, and it's what Susan said. You need to get the tissue and to look at it and have them really look at the vessels to see if it is, because on the surface you sometimes don't know what you're seeing. And the other is there are a lot of other causes that could cause the clinical feature, or what they saw on the EGD and the scope. And so I definitely would make sure you look at those things, and particularly dysmotility is known to happen, and that would be setting this patient up particularly for potentially an infection or something else that's in there that could be causing some of that.